Okay, so today we will study ventral hernias from the Sabiston textbook of surgery, and the topic is already open, and we will also take notes. So, as usual, multi screen view and notes mode on. Okay, so let's begin. So, ventral hernia. So, a ventral hernia is defined by a protrusion through the anterior abdominal wall. What is a ventral hernia? It's a protrusion through the anterior abdominal wall. So, the topic is ventral hernia. And what is a ventral hernia? It is a protrusion through the anterior abdominal wall. So these defects can be categorized as either they can be spontaneous or acquired or by their location on the abdominal wall. So ventral hernias can be ventral hernias can be either spontaneous or acquired. Spontaneous or acquired. So ventral hernias can be spontaneous or acquired, or they can be categorized by their location on the abdominal wall. Epigastric hernias occur from the xiphoid process to the umbilicus. So epigastric hernias occur from the xiphoid process to the umbilicus, and umbilical hernias, they occur at the umbilicus, and hypogastric hernias are rare spontaneous hernias that occur below the umbilicus in the midline. And acquired hernias typically occur after surgical incisions and are therefore termed as incisional hernias. So acquired hernias are typically incisional hernias. So although not a true hernia, diastasis recti can present as a midline bulge. So there is a thing called diastasis recti. It can also present as a midline bulge, and it is not a true hernia. Diastasis recti is not a true hernia. So let us write that down. It can also occur as a midline bulge. So diastasis recti, not a true hernia. In this condition, the linea alba is stretched. What happens in diastasis recti? Linea alba is stretched, resulting in bulging at the medial margins of the rectus muscles. So what happens in diastasis recti is that the linea alba is stretched, which causes midline bulge. So abdominal wall diastasis can occur at other sites in addition to the midline, and it's not that it can only occur in the midline, but diastasis can occur at other sites in addition to the midline. There is no facial ring or hernia sac, and because it's not a true hernia, there is no facial ring or hernia sac, and unless it is significantly symptomatic, surgical correction is generally avoided. So if it is not symptomatic, we won't do any surgical correction. So let us note down midline bulge. So if asymptomatic, then there is no requirement of surgical correction, no surgery. So incidence. Based on national operative statistics, incisional hernia accounts for 15 to 20% of all abdominal wall hernias. So this might be some US data. So 15 to 20% of all abdominal wall hernias are incisional hernias. Umbilical and epigastric hernias constitute 10% of the hernias. So incisional hernias are more common than umbilical and epigastric hernias, 15 to 20%. Umbilical and epigastric hernias are 10% of the hernias. Incisional hernias are twice as common in women as in men and can occur. So incisional hernias are twice as common in women as in men and can occur to 41% of the time 2 years after oncoresection. An estimated this much ventral hernia repairs are performed each year. Several technical and patient-related factors have been linked to the occurrence of incisional hernia. There is no conclusive evidence demonstrating that the type of suture at the primary operation affects hernia formation. So one important point is that there is no conclusive evidence demonstrating that the type of suture at the primary operation affects hernia formation. So you can use any PDS loop or nylon loop for sheath closure, and there is no conclusive evidence that it will affect later hernia formation. So patient related factors linked to ventral hernia formation include, so patient related factors are obesity, older age, male gender, sleep apnea, emphysema, and prostatism. It has been proposed that the same factors associated with destruction of the collagen in the lung result in poor wound healing with increased hernia formation. Wound infection has been linked to hernia formation. Recent data suggests that surgical techniques used to close a midline laparotomy is highly associated with incisional hernia formation. The surgical technique used to close a midline laparotomy is highly associated with incisional hernia formation. The use of a suture to wound length ratio of 4:1 has been shown to significantly reduce incisional hernia formation compared with the 1 centimeter bites and 1 centimeter advancement suturing technique typically employed by most surgeons. So we have to ensure that the suture to wound length ratio is 4:1. So let us take some notes here. So first of all, let us write down patient related risk factors. What are the patient related risk factors? So number 1 is obesity. Number 2 is older age. Number 3 is male gender. Number 4 is sleep apnea. Number 5 is emphysema. Number 6 is prostatism. So these are patient-related factors. Patient-related risk factors. Okay, so that is just. So risk factors are first patient-related, and then we have wound infection. Wound infection is linked to hernia formation. And then surgical technique to close midline wound. Surgical technique to close the midline wound is also implicated in hernia formation. So, how to prevent hernia formation? So, how to prevent hernia formation? You use suture to wound length, suture to wound length of 4:1 always. Whether the type of initial abdominal incision influences the incisional hernia rate remains controversial. So we do not know if a certain incision increases the hernia rate. As noted, the incidence of ventral herniation after midline laparotomy ranges from 3 to 20% and doubles if the operation is associated with a surgical site infection. So after midline laparotomy, incisional hernia rate incidence is 3 to 20% and doubles if the operation is associated with a surgical site infection. So this is an important piece of data. We will write it down. So incidence of ventral herniation after midline laparotomy is 3 to 20%, and if there is a surgical site infection, then this range would double the incidence. That means 6 to 40%. 6 to 40%. So meta-analysis was done of 11 studies examining the incidence of ventral hernia formation after various types of abdominal incisions, and that has included the risk is 10.5% for midline, 7.5% for transverse, and 2.5% for paramedian incisions. So paramedian incisions are relatively safe from ventral hernias according to this study. So midline incisions have the highest risk of hernia formation. Given the likely similar rates of incisional hernia formation after transverse and midline incisions, the surgeon should plan the incision on the basis of operative exposure desired to complete the procedure safely. Few data are available about the natural history of untreated ventral hernias. As noted, asymptomatic or minimally symptomatic inguinal hernias purposely observed during 2 years have a low incidence of complications. So, asymptomatic or minimally symptomatic inguinal hernias purposely observed during 2 years have a low incidence of complications. So, this is another important piece of data, that even if you do not perform the surgery for 2 years, there is a low incidence of complications in asymptomatic or minimally symptomatic inguinal hernias. So, natural history. So, asymptomatic or minimally symptomatic inguinal hernias have low incidence of complications in a 2-year period. So whether this paradigm applies for asymptomatic ventral or incisional hernias is unclear. So it is only for inguinal hernias, because there is no prospective cohort available to determine the natural history of untreated ventral hernias. Most surgeons recommend that these hernias be repaired when discovered. So the anatomy of the anterior abdominal wall is straightforward and considerably easier to grasp than the anatomy of the inguinal area. However, a clear understanding of the blood supply and innervation of the abdomen is important in performing advanced abdominal wall reconstruction. The lateral musculature is composed of 3 layers. So ventral hernia, ventral abdominal wall anatomy should be clear. So the lateral musculature is composed of 3 layers, with the fascicles of each directed obliquely at different angles to create a strong envelope for the abdominal contents. Each of these muscles forms an aponeurosis that inserts into the linea alba. So there is an aponeurosis formed by each of these muscles and that inserts into the linea alba, a midline structure joining both sides of the abdominal wall. What is linea alba? Linea alba is a midline structure joining both sides of the abdominal wall. The external oblique is the most superficial muscle of the lateral abdominal wall. So external oblique. Deep to the external oblique lies the internal oblique, and the fibers of the external oblique course in an inferomedial direction. So external oblique fibers, they course in an inferomedial direction, and it's like putting the hands in the pocket, whereas those of the internal oblique muscle run deep to and opposite the internal oblique. So internal oblique runs opposite to the external oblique muscle. The deepest muscle layer of the abdominal wall is the transversus abdominis muscle. Its fibers course in a horizontal direction. So transversus abdominis runs in a horizontal direction. These 3 lateral muscles give rise to the aponeurotic layers lateral to the rectus, which contribute to the anterior and posterior layers of the rectus sheath. The medial extension of the external oblique aponeurosis forms the anterior layer of the rectus sheath. Anterior layer of the rectus sheath. The transversus abdominis muscle and the aponeurosis extend medial to the linea semilunaris. So the transversus abdominis muscle and the aponeurosis extends medial to the linea semilunaris, contributing component to the posterior rectus sheath. And midline the 2 anterior rectus sheaths form the tendinous linea alba. On either side of the linea alba are the rectus abdominis muscles. So on either side of the linea alba are the rectus abdominis muscles, whose fibers are directed longitudinally and run the length of the anterior abdominal wall. Below each rectus muscle lies the posterior layer of the rectus sheath, which also contributes to the linear alba. Another important anatomic structure of the anterior abdominal wall is the arcuate line. So there is this arcuate line which is located 3 to 6 centimeter below the umbilicus. So arcuate line, where is arcuate line? It is located 3 to 6 centimeters below the umbilicus. It is important. Arcuate line is located 3 to 6 centimeter below the umbilicus. So the arcuate line delineates the point below which the posterior rectus sheath is absent. Above the arcuate line, the aponeurosis of the internal oblique muscle contributes to the anterior and posterior rectus sheaths, and the aponeurosis of the transversus abdominis muscle passes posterior to the rectus muscle to form the posterior rectus sheath. Below the arcuate line, the internal oblique and transversus abdominis aponeurosis pass completely anterior to the rectus muscle. So the posterior rectus sheath below the arcuate line is composed of the transversalis fascia and peritoneum only. So the posterior rectus sheath below the arcuate line is composed of the transversalis fascia and peritoneum only. The abdominal wall receives most of its innervation from the intercostal nerves. So innervation of the abdominal wall from intercostal nerves 7 through 12 and the first and second lumbar nerves. So innervation from intercostal nerves 7 through 12 and the first and second lumbar nerves. These MI provide innervation to the lateral abdominal muscles and the rectus muscle and overlying skin. The nerve traverses through the lateral abdominal wall between the transversus abdominis and internal oblique muscles. So nerve traverses through the lateral abdominal wall between the transversus abdominis and the internal oblique muscles and penetrate the posterior rectus sheath just medial to the linea semilunaris. So the lateral abdominal muscles receive their blood supply from the lower 3 or 4 intercostal arteries, deep circumflex iliac artery and lumbar arteries. The lateral abdominal muscles, they receive their blood supply from the lower 3 or 4 intercostal arteries, deep circumflex iliac artery and lumbar arteries. So the rectus abdominis has a more complex blood supply derived from the superior epigastric artery. Rectus abdominis blood supply is derived from superior epigastric artery, which is a terminal branch of the internal mammary artery. Rectus abdominis supplied by the superior epigastric artery, which is a terminal branch of the internal mammary artery, and the inferior epigastric artery, which is a branch of the external iliac artery. So superior epigastric artery, inferior epigastric artery. Superior epigastric artery is a terminal branch of the internal mammary artery, and inferior epigastric artery is a branch of the external iliac artery and the lower intercostal arteries. Superior and inferior epigastric arteries anastomose near the umbilicus. Superior and inferior epigastric arteries, they anastomose near the umbilicus. The periumbilical area provides critical perforator vessels that, if preserved, can decrease skin flap necrosis during extensive skin undermining. So now the diagnosis. Evaluation of abdominal wall hernias require diligent physical examination. So it requires physical examination. As with inguinal region, the anterior abdominal wall is evaluated with the patient in standing. So how is the patient evaluated in standing and supine position? And with a Valsalva maneuver is also useful to demonstrate the size and site of hernia. Imaging modalities may play a greater role in the diagnosis, and CT evaluation and surgeon performed ultrasound. So you can go for a CT or you can go for a dynamic abdominal sonography for hernia dash. You can go for a dynamic abdominal sonography for hernia dash. So coming to diagnosis. Diagnosis is through physical examination, thorough physical examination. So physical examination needs to be done in standing position supine position, and also with the Valsalva maneuver. Then you can go for CT abdomen, and also you can go for dynamic abdominal sonography for hernia, which is dash. Dynamic abdominal sonography for hernia, which is dash. Dynamic abdominal sonography for hernia. So now let us classify umbilical hernias. Umbilical is formed by the, so I have already underlined these text. So the umbilicus is formed by the umbilical ring of the linea alba. How is the umbilicus formed? It is formed by the umbilical ring of the linea alba. So intra-abdominally, the round ligament, ligamentum teres, and the paraumbilical veins join into the umbilicus superiorly, and the median umbilical ligament, that is the obliterated urachus, enters inferiorly. So umbilical hernias in infants are congenital and are common. Okay, so let's make notes. Umbilical hernias. So umbilical is formed by the umbilical ring, and umbilical hernias in infants are congenital and are common. So number 1 point is, in infants, umbilical hernias are congenital. Number 1. Congenital, and they are common. So in infants, umbilical hernias are congenital and they are common. So also they close spontaneously in most cases by the age of 2 years. Close spontaneously by the age of 2 years. So those that persist after the age of 5 years are frequently repaired surgically. So when do we have to do surgery in infantile umbilical hernia? So surgery has to be done if hernia persists after 5 years. So although complications related to these hernias in children are unusual, so also we have to keep in mind that the complications are unusual. So low complications are there. So there is a strong predisposition towards the development of these hernias in individuals of African descent. So this is the diagram of the cross section of the rectus abdominis muscle and aponeurosis above and below the arcuate line. So we can clearly see that this is the anterior layer of rectus sheath, this is the posterior layer of rectus sheath, and this is the linea alba. So this is the external oblique, internal oblique, transversus abdominis, So internal oblique is splitting to form this anterior layer of rectus sheath as well as posterior layer of rectus sheath above the arcuate line. Below the arcuate line, all three muscle layers, they form the anterior rectus sheath and does not go into the posterior rectus sheath. So posterior rectus sheath below the arcuate line is formed by the the peritoneum and transversalis fascia, and this is the urachus in medial umbilical fold, and this is the medial umbilical ligament and fold. So this is the basic diagram, and this is the cross section of the lateral abdominal wall detailing location of the intercostal neurovascular bundle traveling between the transversus abdominis and internal oblique muscles. So here is the neurovascular bundle. So now let us talk about the adult inguinal hernias. So this was infantile adult umbilical hernia. So this was infantile umbilical hernias, and now we'll talk about the adult umbilical hernias. So they are largely acquired. And they are more common in women. So adult umbilical hernias are acquired and more common in women. So why do they occur? So the risk factors would be number 1, increased intra-abdominal pressure such as pregnancy. Secondary, obesity. Pregnancy, obesity, ascites. So basically any condition that can increase the intra-abdominal pressure, or chronic abdominal distension. Chronic abdominal distension. So it is basically anything that increases intra-abdominal pressure. So anything that increases intra-abdominal pressure would cause umbilical hernias in adults, which are largely acquired and more common in women. So next point is that strangulation is unusual in most patients. So next point is that strangulation in umbilical hernias is unusual. So strangulation is unusual. However, it is written that strangulation or rupture can occur in chronic ascitic conditions. So if we have a patient with chronic ascites, then if we have a patient with chronic ascites, then we might have to face strangulation or rupture is more common. So strangulation or rupture is more common, and if there is a spontaneous rupture of umbilical hernias in patients with ascites can result in peritonitis and death. So if there is a spontaneous rupture, it can result in peritonitis and death. So small asymptomatic umbilical hernias barely detectable on examination need not be repaired. The next point is that small asymptomatic umbilical hernias, we don't need no surgery. And who needs surgery is the next point. Next point is indications for surgery. So number one indication is adults who have symptoms. So symptomatic umbilical hernia. Number two is large hernia. Large hernia. Number three is incarcerated hernia. Number four is thinning of the overlying skin. Overlying skin. Thinning of the overlying skin. Number five is uncontrollable ascites. So we're not able to control ascites, we should perform a hernia surgery. So what are the indications for umbilical hernia surgery in adults? So if it is symptomatic, if it is large, if it is incarcerated, if there is a thinning of the overlying skin, or if it is if the patient has uncontrollable ascites. So classically repair was done using the vest over pants repair. What is the vest over pants repair? It was proposed by Mayo, so it's called Mayo's repair, which uses implication of the superior and inferior facial edges. So recurrence was very common in this Mayo repair, almost 30% with long-term follow-up, and so it is rarely performed today. So defects are closed primarily if the hernia is small. If the defect is larger than 3 cm, then it is closed using a prosthetic mesh. So our last point for umbilical hernia would be hernia repair. So umbilical hernia repair, how to approach it? If it is more than 3 cm, or if it is umbilical hernia is less than 3 cm. So if umbilical hernia is more than 3 cm, we use a prosthetic mesh. That means we will perform a hernioplasty. And if the defect size is less than 3 cm, we will close it primarily. That means we have to perform herniotomy or herniorrhaphy. So this completes umbilical hernia. Next we will read about epigastric hernias. So approximately 3 to 5% of the population has epigastric hernias. Approximately 3 to 5% of population have epigastric hernias, and they are 2 to 3 times more common in men. 2 to 3 times more common in men. So these are located between the xiphoid process and umbilicus, which is obvious, and are usually within 5 to 6 cm of the umbilicus. So they are usually within 5 to 6 cm of the umbilicus. And like umbilical hernias, epigastric hernias are more common in individuals with a single aponeurotic decussation. So umbilical hernia and even epigastric hernia is more common in people with single aponeurotic decussation. So the defects are small and often produce pain out of proportion to their size because of incarceration of pre-peritoneal fat. So small defects which causes incarceration of pre-peritoneal fat. Incarceration of pre-peritoneal fat, which leads to pain out of proportion to their size. Pain out of proportion to size. So they are multiple. Epigastric hernias are multiple in up to 20% of the patients, and approximately 80% are in midline. So they are multiple in 20%, and approximately 80% are in midline. So multiple in 20%, approximately 80% are in midline. So repair usually consists of excision of the incarcerated pre-peritoneal tissue and simple closure of the facial defects. So let us underline this, that how is repair usually done? It is usually excision of the incarcerated pre-peritoneal tissue and simple closure of the facial defect, similar to that for umbilical hernias. Small defects can be repaired under local anesthesia. Uncommonly, these defects can be sizable, can contain omentum or other intra-abdominal viscera, and may require mesh repairs. Epigastric hernias are better repaired anteriorly because the defect is small and fat that has herniated from within the peritoneal cavity is difficult to reduce. So, repair as an umbilical hernia is according to the defect size. If it is small, then we do a primary closure. If the defect is large, then we use mesh and do a hernioplasty.